I wondered, to kind of ease into our conversation, is there anything that you wish you would have known before you were diagnosed with PV that you now know?
I wish that I would have known that I was actually having symptoms that were likely of PV, because they went on for several months. I was having some dry eyes and some visual disturbances and just not feeling 100%, but I related it to age and not to PV. I wish that I would have known at the time that those were likely symptoms of PV.
I had some of that too in that mid-40s transition time frame. I had previously 3 years clots that was misdiagnosed or overlooked. I've seen some top cardiologist firms in the Houston area, so it's not really a lack of access to healthcare, but it was just no one tested for it.
I think I had similar through my teenage years and early 20s. I had a lot of clots that weren't diagnosed as anything. They were kind of written off as sports injuries. A lot of the hematology tests came back. The first ones when I was 17, so that was part of like pediatric panels. And then I had other symptoms too, I had migraines. No one really was able to pinpoint what was going on until much later when we kind of exhausted everything and we ran a JAK2 test and it came back positive. I wish I would have known is just that these symptoms were pointing towards MPN for about 10 years before we actually got the diagnosis, and once the diagnosis came, things got much better.
I think that's just so important. At those major inflection points, great to go out and find someone who's an expert in exactly what you're dealing with.
I think for me personally, it had been 5 years since I had had a CBC, because I always come into my annual visit not wanting to complain, life is good, just want to stay vibrant and active. I'm not being a complainer. I knew I had an enlarged spleen. My brain didn't really want to compute what that swelling was. I knew it was significant, but I just wasn't willing to admit to it.
I was actually I describe them as rainbowish kind of lightning bolts, kind of weird visual disturbances, some really red skin, a lot of headaches. I went to my primary care physician to have my regular routine physical. I got a phone call a couple days later saying, hey, we need you to come in. Your red blood cells, your white blood cells, and your platelets are all elevated, which was really weird to me and kind of scary. I took a friend with me because I was terrified, and I called my primary care's office, and we went in, and she explained that you need to see a hematologist. They just slid me right on in, 2 weeks late, less than 2 weeks later. And she diagnosed me, explained to me that PV was something that thickens your blood and that you have so many blood cells. We need to put you on this medication that's going to reduce a lot of your blood cells, which was hydroxyurea. So that's how I got my diagnosis. So from a familiar hematologist, and she put me on hydroxyurea.
We used to think that controlling red cell count is enough. It is not enough. So there has been a major change in the PV community, like MPN specialists who would treat this disease, that not only achieving a hematocrit less than 45% is the goal in patients with polycythemia vera, achieving a normal white blood cell count, particularly less than 11,000, and a normal platelet count as well, is extremely important. So for instance, in the past, when we used to use, let's say, a hydria, right, hydroxyurea, and the chances of controlling the hematocrit is very good with that drug. But in many instances, you're not achieving, for instance, the control on the white blood cell count or the control on the platelet count. And there has been many new studies showing that we need to achieve that control in those other cell line as well to provide the patients with better disease control as well as decrease the risk of thrombosis in the future.
So that's really a shift of thought in terms of treatment.
Well,
yes, that is definitely a shift, exactly right, that now we know we have to achieve those points, and if we don't, risks of other complications like blood clots can happen.
So to get diagnosed, I think, much like you, the first real sign was a CBC.
What does that mean?
So a complete blood count, so counting the numbers of the various types of cells in your blood, right?
I usually say that's so important to your annual blood work, right?
Yeah, and I think, maybe for me, it actually stayed masked for a little bit because I got diagnosed in my 30s. A lot of risk models for things they look for only start at 40. So they don't know what to do for you in your 30s. So I got that CBC, and hematocrit elevated, platelets elevated, white blood cells elevated, and the doctor kind of went, could be anything, let's watch it. I went back and pulled other lab work that I had done, and and saw, oh, actually these counts have been consistently elevated over a few years. But when I went back with that information, that's when I got the referral to a hematologist.
Tyler, you have an interesting journey to diagnosis story.
It was during basketball season my senior year. And basketball for me was used to kind of stay in shape between soccer and baseball. Did not like basketball, but needed to keep playing something. And I was tall, so I just kind of got forced. I had severe pain in my leg, and being a 17-year-old, like, pain usually goes away, and it's something that you can just shrug off, take a bunch of Advil, it'll go away. It's like sports injuries. I didn't really have any idea. I had never had chronic pain before, and it just kept getting worse and worse and worse. And finally did ultrasounds on my leg and found a DVT. And so I had to sit out my senior year of baseball, which was my favorite sport, so that was terrible. I was the captain of the varsity team. I was like, I don't know, as a 17-year-old kid, I'm gonna go play professional baseball somewhere. In grad school, as I was actually finishing up my PhD, I had severe abdominal pain, and it was while I was interviewing for fellowships. And so, in my mind, again, not really knowing pain, like pain is just, maybe I'm stressed, maybe these interviews are kind of getting to me and I just need to sleep some more. But I got to the point where I couldn't sleep and went to the ER, and they found a clot in my liver and spleen and mesentery. There was actually a physician's assistant that asked if I had ever had a JAK2 test done, and I said no. And so they did it, it came back positive. I was transferred to a more academic hospital, University of Michigan, and they did all the bone marrow biopsy and everything, and I got the diagnosis of PV.
So you were in college when you were diagnosed?
I was
Grad school.
I was right at the end of grad school.
I was going to ask you if all your, did that affect, is that related to what you're studying now,
So,
in the cancer area?
Oh yeah, what came first?
Yeah.
I know. So cancer biology PhD came first.
Okay.
MPN postdoc was a deliberate choice.
Okay.
Yeah.
I'm just curious, any of you have the experience of, being diagnosed with one MPN before PV?
I didn't necessarily get the official ET diagnosis, but that's what my GP called my platelets were high, closer to 800,000. I was a regular blood donor, so I think unbeknownst I was doing the phlebotomies, not knowing about it. I mean, it was funny because we always dismissed it because of I am an avid blood donor, so platelets come up higher.
My hematocrit, if being honest, wasn't ever super, super high, especially for a young a guy playing sports. That was also why when they were running those tests, they were just kind of like, oh, okay, it's in the 60s, and they kind of just said, you're fine.
But didn't that make you feel awful then? Like, I remember mine was 57. I just felt really bad.
Yeah, I also donated blood a lot, so I was probably phlebotomizing myself and not realizing.
Same, I had the bleeding disorder. I had menorrhagia too. So it was kind of working the same way. And my doctor's like, you may have had this a lot longer than we know of because you had the menorrhagia.
Right.
You could have been could work kind of like a phlebotomy of sorts.
I want to add the point here that the guidelines to diagnose polycythemia vera have changed a little bit in the past decade. In a sense, and the WHO in 2016 made a conscious effort to lower the hemoglobin and hematocrit level to test for JAK2 mutation so that we can catch more patients who have polycythemia vera. So in the past, some patients could have been missed because they have not reached that level that would trigger us to test for it. And the testing modalities that we have to catch JAK2 these days are much more sensitive than the one that we had a few years ago. So we're definitely able to diagnose more patients rapidly with the disease and address whatever symptom or address their disease process much earlier.
I've had this happen a few times, very similar cases where because the patient was an avid blood donor, they were self-phlebotomizing effectively, just like you guys are mentioning, and then that kept the hematocrit lower than it actually would have naturally been, and it sort of masked the actual condition. I tell medical students, residents, that this is an important point. You got to ask the patient because they won't mention it, but it could be medically relevant to understanding the patient's hematologic situation.
Susan, you were diagnosed during COVID?
Tyler and I were talking about this earlier. It was a difficult time.
Yeah.
I'd been having some really heavy chest discomfort on the left side, and visited a friend who was a cardiologist on his lunch hour to say, I really don't want to go to the emergency room. He didn't do labs. It was his lunch hour. And he did an echo, and everything looked great. But what was missed was I was hypertensive. I've always been hypotensive, but that should have been a point of concern. Diagnosed 6 weeks later.
Wow. What is it you want people who are newly diagnosed to know about PV?
I always try to teach the patient that polycythemia vera complications are different than other cancers complications. For instance, with polycythemia vera, you think about a blood clot, it can be a stroke, it can be a blood clot, as Tyler mentioned, as a DVT or a deep vein thrombosis, or it as well can be a blood clot in your heart vessels, leading to a myocardial infarction. Another thing that we teach the patient about is enlarged spleen, and very rarely the patients with PV, their disease can progress to something different, such as myelofibrosis. And the last thing that I tell them is we have many options to treat this disease right now. Always patients are scared, like what if I try something and it works and stops working? What am I going to do next? So we're very lucky that we have many options. And some of those options are not chemotherapy.
I like to echo the first point that it is a cancerous condition. And I say that not so the patient gets scared. I don't want them to feel scared or nervous by hearing that it's a cancerous condition, but I just want them to know very openly and very clearly that, hey, this is a serious condition, but thankfully by proper management and modern treatment options and all those kind of things, we can get you on a much better path where you'll probably be okay. Also, people hear gene mutation and they often think, oh, is it a gene I can pass on to my kids? Or did I inherit it from mom or dad? That kind of thing. Natural question, but we can reassure them that it's not inherited condition, typically speaking.
So let's say if I have polycythemia vera, my offsprings might be at a higher risk of developing some type of MPN, but it's not genetically inherited.
You mentioned risks and complications. How do you explain those risks and complications that are associated with PV to your patients?
This is one of my sort of soapbox points in a way, that this is what we call a hypercoagulable condition, a prothrombotic condition, a condition that can lead to a much higher risk of blood clotting, and many studies have shown this over the years. And polycythemia vera, or myeloproliferative neoplasms in general, is a condition that has a much higher risk of clotting for the person. Second thing is the cardiac risks for the patient. Third thing is symptoms that the patients will face. There are many other possible consequences that can happen, some of which Dr. Elchayer also mentioned, like acute leukemia in some smaller percentage. And also we tell them that, hey, part of our job as the specialist here is that our job is we're going to be monitoring you, asking you the right questions, to do our best to stay on top of it, detect problems before they come up.
I mean, we've been learning a lot about MPN in general and polycythemia vera over the course of the past decade, I would say. And in the past, we used to stratify patients into two groups, right? Like if they are above age of 60, or if they have history of blood clot at any age, then automatically you're high risk. Now we're learning more that this disease not only put you at high risk of a blood clot, but if you have other medical conditions, such as diabetes, hypertension, history of coronary artery disease, this will add more to your risk score. You have to control your other conditions, because if you don't control them, if you're smoking, if you have diabetes that's uncontrolled, high blood pressure that is uncontrolled, high cholesterol that's uncontrolled, all of that will add to your risk.
What are your treatment goals for managing your PV patients?
Managing PV patients, honestly, I focus a lot, number one, on quality of life. So you need to get that person back in the society to treat their disease. If they have a blood clot, and make sure that this is not going to be a recurrence for them. And he survived many blood clots, and I think you're very lucky with the last one. As you were describing, it was quite a large one. The last thing is I want to make sure that the patient's disease doesn't progress. I'm choosing to either delay myelofibrosis, progression to that stage, or, God forbids, if it progresses to acute leukemia.
As a chronic condition, again, the patient's going to be unfortunately living with this condition for the rest of their life. So how can we help control symptoms, minimize the risk of some of these complications of polycythemia vera, like blood clots? I'll talk to them about treatment choices as a separate kind of thing, but can I do those things, help them get in some kind of response or remission, in the bone marrow and help them live their life as best as possible going forward, because I hope that they have many, many years to live, hopefully a natural, good, long lifespan. And it does require some medical intervention, and that is unfortunately part of the package that you're going to have to come in and get follow-ups and get blood work and take some kind of medicine of some type, impossible to avoid it. But hopefully by doing these things, they can live their life also.
I wanted to ask our patients around the table about disease progression. From an emotional standpoint, I have some statistics. From a leukemia standpoint, when not treated, up to 10% of people with PV may develop AML within 10 years of diagnosis. Thinking about myelofibrosis, when not treated, 10 to 21% of people with PV may develop NF within 10 years of diagnosis. What's the emotional impact of that?
I think it's scary. It's really scary, because you're thinking, how long will I live with this disease? Will it progress?
Right.
I think it makes you look for the best treatment out there.
Yeah,
Really makes you look for the best treatment, the one that you want to be on for the long term, the one that you think and your doctor thinks is going to work the best and help prevent that progression.
I think I was diagnosed in my late 30s, and I'm in my early 40s now. And so, to me, if I want to live a natural lifespan, right, I'm looking at 30 or 40 years of living with PV, unless there's a cure invented somewhere along the way, right? So that really made me want to be a little more aggressive in my treatment of the PV, because I'm not just thinking about the risk of disease progression or transformation in a year or a decade. I'm thinking about that over a really long time period. So that made me want to be aggressive in trying to treat the disease.
Jumping in, what was your first journey with you and your doctor after the diagnosis? What was that first, several treatment journey with y'all?
Thankfully, I live by a major cancer research center, so I had a friend that pushed me that direction. That's where I started educating myself. And when I saw my doctor, she was like, like you said, it is a cancer by the definition, but let's get past that. Let's focus on what we can do here. I was on hydroxyurea maybe a month at the time or something, not terribly long. And that's where she said, I really want you to look at the interferon. So I think my son was like 15 at the time. And so seeing him progress through high school, through college, grandchildren, that was key to me, right? Because I was in my mid-40s, so I got my 50s and my 60s. So that's where I learned to be more self-advocate about that, started researching, looking at things.
Once my PCP referred me out to a hematologist oncologist with an academic, through an academic institution, he was like at a satellite clinic in my community, so it was a no-brainer. Of course, I went to visit him, and but before I went, I dove into the research, and so when we walked into his office, I had about a half-inch thick, folder of journal articles and evidence-based practice. I knew I wanted interferon treatment. I got shot down because I was 61 years old, and the cutoff was 60, and I was considered high risk. I was not considered low risk. So we walked out of that appointment really feeling deflated, but he said one key thing: you could certainly visit my colleague over at the main campus, and you could run it by him, and that's exactly what we did. And Dr. El-Shar was that physician. We landed in his office.
Oh, wow.
We had our folder. We didn't even have to open it up. He just said, absolutely, without a doubt, you need to be on interferon. So, we walked out of there feeling a whole lot better than we had 2 weeks earlier.
I think it's very important that the patient is educated about their disease for many reasons. Number one, they become much more involved in the treatment journey. By being educated, that fear that they came with the diagnosis subsides quite substantially once you understand the disease, you understand the drugs, and you understand the ultimate goal that we're all working toward. There's a lot of options these days to read about everything. I try to steer them towards credible sources. For instance, there's the Blood Cancer United. They have amazing resources that are written by physicians and by patients' advocacy group, as well as by healthcare, professionals, geared towards the patient, written in layman's terms to understand everything from what is a bone marrow biopsy, what is a JAK2 mutation, There are other resources. The NCCN guidelines, they have a section dedicated for the patients. And the MPN Research Foundation, they have amazing interactives, options for the patients to read about. The last thing that I would like to mention as well is there's like support groups, right, that are very active in the MPN world in general. They can be a source of information for the patient because they get to connect you with other peers and other patients who have disease. But I would like to make sure that the patients understand your case is not the same as everyone else in that group. Some instances the patients come to me and they're like, I go on these Facebook groups and, some patients, they have disease progressed, very quickly. Like, am I going to be that person? And, you have to be always careful when the information presented to you is not coming from a healthcare professional.
I can imagine that finding the right doctor who is knowledgeable about MPNs and PV in particular is necessary. Kevin, I think, did you have a tricky navigation to find like the right doctor?
I did. So I started out at a community hospital essentially, and the answer I got a couple of times, right, from a couple different doctors was watchful waiting, right? So you're going to take aspirin, and then we're going to wait until you're high risk, and then we'll treat you, right? Which I think now, like according to the NCCN guidelines, is a little old-fashioned. Especially for someone with symptoms. I really wanted to find a doctor that would engage in that shared decision-making with me and be a little more aggressive about the treatment. I also walked into that next appointment where I finally got prescribed some medication to help me control the disease with, a pretty clear idea like, hey, I want to be on interferon, here's my stack of paper, and let's talk about this, right? I eventually found the right doctor, and I know that there are websites out there that have that list of, here are the MPN experts. I did go on clinicaltrials.gov because after getting that watch and wait answer a couple times, I was like, well, maybe there's a clinical trial for me. And I just kept seeing the same names pop up again and again in the myeloproliferative neoplasm space, right? Doctors who were a part of clinical trials. And so, I thought, well, if this doctor is constantly studying these diseases, they must be an expert in it.
From a physician's perspective, what would your advice be to a patient that's maybe a little bit unsure if they're in a good fit with their doctor? Is it okay to get a second opinion?
Yeah, educating the patient is so critical because as a chronic condition, lifelong disease, one of the real world things that I've seen over 20 years quite frequently is that patients have moved from somewhere else. So you move somewhere else, you got to reestablish with a different physician, and you have to kind of self-advocate, which is another key word over here, is like to advocate for yourself as a patient so you can communicate, what are your goals, what have you been doing, what's been working so far. And that's not always easy because it does require some, in a way, I think of it like bravery to self-advocate, because you're sort of like going up to a trained professional and effectively sort of telling them what's been going well for you, And like all these things, there's never like one size fits all. In the hematology oncology world, in the cancer medicine world, the idea of a second opinion is very normal. So they won't be offended. People won't be offended. And then you never know. There could be a modification of the diagnosis that could be helpful in a nice way. So ultimately, I think it's very helpful, happens all the time.
You did seek a second opinion, right, in New York? Am I wrong?
You were my second opinion.
So it was not you.
I guess I'll maybe go a step further and just say, to me, like you have a team for your care, right? You have a hematologist, oncologist, you have a primary care physician, you have like you are a really important member of the care for your team, and it is okay to, kind of exercise your right as, the manager to change out the members of the team, right? It's a team. It's not a family. You can make a trade.
Kevin, I think you mentioned a while ago that very buzzy term, shared decision making.
Yeah.
And I kind of think of shared decision making. It sounds clinical, kind of in a way, but it's just collaborative conversation with your physician, asking table-wide, what has been the value of engaging in shared decision making in your own care and managing your PV?
So I think to me, like the process to me ideally looks like the patient and the physician are going to establish treatment goals together, right? Goals should come from you as well as the physician, and then you're going to talk about treatment options, and that information is probably going to come from the physician, right?
I don't know, you guys brought in papers.
Yeah, which I'm sure was, appreciated to a degree and not appreciated to another one. You talk about the treatment options and the benefits and risks of those treatment options. Same way you'd approach the relationship probably with any other, kind of professional that you need help from, whether that's a lawyer or a CPA, financial advisor, right? You're going to have some goals and they're going to have some potential solutions, and you're going to talk about those together.
Yeah, and I think it becomes personalized medicine when you're in a collaboration with your hematologist oncologist, right?
Right.
I think it's a relationship, right? You're building with another person, and they can build upon your strengths too. And my doctor personally, she asked me, well, what do you think? Because she knows I do a lot of research. But when she goes a step further, not like, what do you want to do? It's like, why? I have to prove why I want to do something. Then we have that conversation, why my thoughts are not really working or good or not, or like, oh yeah, that's a great thing, type thing. So I think that's where you're very personally, right? Because not only dealing with the true physical impact, but she's dealing with my emotional and my psychological of why I think something. And I think that's very personal. She knows me, she knows I'm telling her the whole story, so that way she can make the best decision or help me make the best decision for me.
Sherry, what was your journey to get on BESREMi? You started with chemotherapy, is that correct? What was your journey, your treatment journey?
I started on with the hematologist that I was seeing for my original bleeding disorder that diagnosed my polycythemia vera, started me on hydroxyurea. And I was actually on hydroxyurea for, 6 to 7 years, I think it was.
7 years?
Yeah, longer than I like to remember. I say it was working because it was keeping my blood counts lower, so which was, I guess, is the goal of that drug. But I was not comfortable being on chemotherapy. I didn't like that I had to take chemotherapy every day. I didn't like that there were long-term side effects of the drug. And then I thought, let me do my own research. And I joined some support groups and started hearing about the interferons. So I'm like, I think this sounds really interesting. Like, I think this is what I want to be on. So I brought that back to her, and she was very hesitant because of some of the awful side effects of the interferons, which she's basically used, I think, with hepatitis patients. And a lot has changed since then. I continue to take the hydroxyurea. I went back again, and I was very persistent. And she's like, okay, this is what we're going to do. I'm going to send you to the MPN specialist at our teaching hospital. And that's when I went to my current physician, and she's like, oh, absolutely, you need to be on interferon. Like, you need to be on BESREMi. So she's very excited about the interferon. She's like, this is really the best drug for the long term. And I don't know what magic happened behind the scenes, but something took place, and the drug was at my house on my doorstep within a very short period of time through, I believe, Pharma Essentia Source. I've been on it about 4 years now, and I still see that same physician. So,
what drew you to this particular treatment? What drew you to BESREMi rather than chemotherapy?
I think because it treats your disease at the source. Like, it's common sense to me.
Yeah, I was always an advocate for health promotion, so it just made sense in my brain that I would want to do something that would prevent further damage.
When patients come to my office, especially young patients, I almost never offer hydroxyurea for these patients because, he has 40, 50 years ahead of him. And yes, we have some safety data about hydroxyurea on the long term, but I put myself in the patient's shoes. Like, if I have an option that is not chemotherapy, why would I want to take chemotherapy? If you have other options that can address the disease at its source, why would I not choose that?
I want to ask a little bit about the importance of treating PV at the source.
Ultimately, you want to try to control the disease itself, the medical problem itself. So it's sort of like the analogy I like to give is that imagine somebody has pain from an injury, and if the injury is a broken bone, let's say hypothetically, and you take a pain medication, the patient feels better, but the problem is that you have to fix the broken bone. So the same kind of idea over here is that you can do things like therapeutic phlebotomy, the typical blood donation phlebotomy approach, which will make symptoms better, but only temporarily, because you are physically removing blood every time you give a blood donation or do a phlebotomy. But it's ultimately not treating the actual condition in the bone marrow. The actual cancer in the bone marrow is not being treated. And so that's like philosophically the reason we aim for now better therapies that can induce responses against the Polycythemia vera at its source within the bone marrow itself.
In general, phlebotomy is a safe procedure. But again, I tell my patient this is a Band-Aid, right? Like you're not addressing the disease at its source.
Dr. Mehta, I was wondering if you could explain how BESREMi works.
Yeah, so BESREMi is one of these newer treatments, relatively newer treatments that can now actually treat the Polycythemia vera at its source inside the bone marrow. So the analogy I give to my patients is that imagine it's like a thermostat, in the house. And the thermostat normally should be with all the fine circuitry and all that kind of stuff, regulating the heat or air conditioning in your house. This is like the thermostat's broken. The thermostat's broken and the body is just putting out too much heat, kind of like the heater is broken in the house and it's just blowing hot air, even though the thermostat should be setting, okay, hey, we don't need any more heat, turn it off. So when you fix the thermostat in the body, in the bone marrow, you're able to not just regulate the red blood cells getting back to normal, but the white blood cells and the platelet cells also. So all three of the main blood cells in the bloodstream are being worked on by BESREMi.
What was your journey getting on BESREMi?
We tried phlebotomies for a while. I was needing like 4 to 6 a month. I mean, it was just insane. It was just like not possible. When the phlebotomies were obviously not sustainable, I was moved to Pegasus, and that is weekly. It was a very uncomfortable situation because I felt a lot worse because of treatment that I was receiving than the disease that was underlying. But if I didn't do anything, now there's that fear and anxiety of this shadow chasing me of transformation or progression. And so I knew I had to do something. And so I started taking the Pegasus, but it really took me out of my normal life. I had to completely stop playing sports. Just my joints got really inflamed and I got very stiff. It got to the point I would get down on the floor and like with my dogs or whatever, and like it was hard to get up. And I was, again, like in my upper 20s, so it was just very odd. And when I transferred to WashU to start my fellowship, that was also just coincidentally the same time that BESREMi was approved. And my physician even told me when I moved there, he said, as soon as it gets approved, we'll just move you to that. As soon as it was approved, we switched to it. It was very incredible to me. I've needed about 4 phlebotomies in the last 5 years, which is a very big change from prior.
So how has it helped your PV?
I only take BESREMi twice a month, so I think about PV much less. I feel much less like a cancer patient. I don't have to have phlebotomies, which is also wonderful because that's a rather large needle and it's a lot more painful than just getting your blood drawn. And I just feel like I'm on the right treatment for me for the long term. I'm very confident in this treatment.
I was so taken by that statement. I don't feel like a cancer patient.
Yes, I know. Well, you think chemo goes with cancer, So that was really difficult for me. Nobody ever thinks they're going to take chemo,
What's interesting about BESREMi, even though it's a cancer treatment, it's not chemotherapy. It's one kind of immunotherapy, so to speak, or immune system therapy. Interferon is a natural molecule in the immune system in the human body, separate from a medication being prescribed. And so this is an immune system therapy or immunotherapy. Some patients may feel comfort knowing that this is not traditional chemotherapy, even though it may be a treatment for cancer.
I give myself an injection once a month. And other than that, beyond trying to live a generally healthy lifestyle as much as I can and control, other, cardiac and circulatory kind of risk factors like we all should, this is just something that is just one very small part of my life rather than being a focus of my life, right? I'm not a professional patient. I'm not going to doctors day in and day out. It's really just allowed it to go into the background. And like, I think many of you, I haven't needed phlebotomies. I reached hematologic remission, meaning, all my cell counts were in the right range after, just about 12 weeks, I've stayed there. So it's just allowed me to get on with my life. I think I found that with my symptoms too, right? That I didn't really realize what my symptom burden was until it was alleviated somewhat, right? So I kind of had the energy to go work, home, couch.
Just getting old. I thought I was just getting old.
Yep.
That's what I blamed all my symptoms on. Well, I'm 50 now. Now I'm 55. Now I'm 60. And
I just thought I was lazy, lacked energy, working too hard, whatever. And then as the medication worked to control the underlying disease, the symptom burden lessens, and then I have the energy to do things I want to do again and to, try to be the kind of dad that I want to be.
I resonate so much with what you're saying. When I was first diagnosed, and especially when I started getting treatments, and I was really concerned about my career, like being able to keep going with such a demanding schedule and trying to keep up with my peers. It wasn't until I made that switch to BESREMi that I actually felt confident, like you said, confident this is the right treatment for me, but confident that I can keep going in what I was trying to build as a career.
The comments that you guys are making just from your own direct experiences are really both really enlightening, but also make us feel good, I think, as physicians, that okay, you can forge ahead in your career, your job, your day-to-day life. I mean, that's such a big deal.
You've mentioned to feel like you don't have cancer anymore. I was wondering, how often do you think about your PV now that you're on BESREMi?
I think when I take the injections, right? The specialty pharmacy calls me the week before and says, hey, what day do you want us to deliver it? And then I take the injection. And other than that, certainly my family and close friends, knew about my treatment journey, right? And so every once in a while, I'll even get the like, oh, how are you doing? And I'm like, I'm great. You? I forget that that's what they're referring to, that they knew at some point that I was kind of searching for a diagnosis and for treatment. But like it's, gone that much into the background that somebody will give me the, how are you? And like, good, you? Why are we being weird?
I only think about it every 2 weeks when I take the injection, and every 6 months when I go to my oncologist. And when I fly, do I need my medication? How am I going to get my medication on the plane?
Dr. Mehta, I was wondering if you could share a little bit about the results of the clinical trial, and Dr. Elshayer as well. What were the results? What was the percentage of response to BESREMi?
Yeah, so the clinical trial, first of all, there was a number of patients that were either new diagnoses, newly diagnosed patients, first starting on BESREMi, as well as other patients who have already been on treatment with other therapies like phlebotomy, hydroxyurea, et cetera, and then we're switching over to BESREMi. So the nice thing is that both types of broad circumstances were tested in clinical trials and see what is the response in these patients, reflecting like what happens in real world medicine. So the overall response, where we talk about like the blood counts normalizing and no phlebotomy needed for at least 2 months or more, that combination was hit in 80%. So 80% were able to achieve that result. Just to explain that, yes, it is very likely you'll respond, though it's not 100%, but very likely all blood counts normalize, not just the red cells, but the white cells and the platelet cells also, and the phlebotomy need goes down long term. So quite strong data, in my opinion, as a hematologist, that you can achieve this for the majority of folks that are receiving the therapy.
Read this important safety information carefully. It explains the serious risks of BESREMi and how to take it safely. Talk to your healthcare provider if you have any questions. What is the most important information I should know about BESREMi? BESREMi can cause serious side effects, including conditions that may cause death or may worsen certain serious diseases you may already have. If symptoms get worse or become severe and continue, your healthcare provider may tell you to stop taking BESREMi permanently. These symptoms may go away in some people after they stop taking BESREMi.
Dr. Elshayer, will you explain why patients get those flu-like symptoms when they take BESREMi.
Absolutely. I think Dr. Mehta mentioned, BESREMi is an immune therapy, like immune modulator, right? So it works on the immune system. Primarily, it activates the immune system. And when the immune system is activated, it releases cytokines or molecules in our body. And those molecules are almost the same one that are released when we have flu or we have any other viral infection. So you're feeling the cytokine side effect in your body from BESREMi, basically. And this is like why the patients develop these flu-like symptoms. But I want to point here that in the clinical trials when BESREMi was tested, about 60% of patients or so experience flu-like symptoms. But if you look at the grade 3 and grade 4, which is basically enough to either dose reduce or enough to bother the patient's quality of life, is only about 2%. So most patients, do well on the drug without having the major side effect of flu-like symptoms that can affect their quality of life.
When I was on that process of increasing my dose, when I started titrating up, I noticed the flu-like symptoms then. And I think for me, that was, maybe more than just the aches. Like I had the, teeth chattering, like felt like I was feverish. During that time, just some, prophylactic Tylenol and trying to time my dose later in the day so I could, maybe sleep through that part of it. After that first couple doses, talking with my doctor, I learned to kind of take those steps. And that made a world of difference for me. And since then, like others, I over time switched from that every 2-week dose. Once I reached complete hematologic remission, switched to monthly dosing.
Stephen, you had flu-like symptoms with BESREMi. What motivated you to keep going despite having those symptoms?
To be honest, I still do have flu-like, not at different degrees, but for me, we'll go back to that theme earlier, progression, right? I have at the time I was a young son. So for him, has been my focus there, right? My compass of, hey, if I want to see him progress through his life, I have to be around. So fighting that progression was like, you know what, I can put up with this. It's not a daily treatment, so once every 2 or 3 weeks, depending on your treatment plan, that's completely doable. So you hear flu-like, but for me, it's like I'm getting the flu, right? It's not like I have the flu, but it's like I feel like I'm about to. The aches. I always say, and some people I even tell, I've worked with colds that I felt worse with, but you do feel it. I get it, and I think it depends. For me, it's about 2 to 3 days after the injection. I get it for a couple of days, and I just feel icky for a few days.
And if I can underscore 2 points that are like really nice points you guys have brought up that I think are good for patients to know in general is that one is that we can adjust the dosage. So if the dosage is causing some kind of side effect, we can adjust the dosage that fits their particular case best. So there is room to maneuver. So that's always a good thing for the patient to know. It's not one fixed dose. We have room to maneuver to get the right dose for you. Second thing is that, as you guys have said exactly right, of course, that eventually the frequency of how often you take it will become just once a month effectively. Initially it's every other week, twice a month essentially, but long term it becomes once a month. So you take it less often, 1 shot a month. You can see why side effects tend to be less noticeable because you're getting the medicine less, and only once a month.
I think a key there though too is everybody's different. You just got to, working with your doctor to figure out, like you said, you can adjust your dose to fit your needs.
That continued shared decision making even when you get on medication.
Kevin, you mentioned 12 weeks. Blood tests were within range after you started the medication. This might not be true for everyone, right? In the clinical trial, it takes about 8 months or so for the median, which most patients to get that happy medium of complete hematologic response. So when I see a patient, I tell them, it's a great drug. It's not a magic drug. You're not going to wake up tomorrow and your CBC or your complete blood count will be normal. Like, you have to set the expectation so that when they come next month or the second or the third month and their counts are still not within the range, it does not mean the drug is not working. It just takes more time for some patients to work as it's intended. So I think this setting up the expectation from the very beginning is extremely important so that you don't lose trust in that drug or switch to something different too prematurely.
Yes. I want to thank you all for being here today. I know this table feels very passionately about advocating for oneself and for your health, Just to close out, any words of encouragement to patients, to caregivers that might be watching this? Is there hope in PV? Do you feel encouraged in PV? What are your words of encouragement?
I think I would tell somebody, the most important thing I could say to somebody, maybe if it's somebody newly diagnosed, is to be your own advocate. Like, nobody knows you as well as you know yourself.
I really like that. I mean, it wasn't that long ago that no one understood the genetic underpinnings of MPNs or of PV specifically, and there weren't medical treatments specifically for PV. And now, all of us are on some kind of treatment that's working for us.
For the patients, I tell them it's chronic disease, and there's so much more to come, hopefully in the next few decades, and maybe one day we'll reach the cure.
I think it's great for physicians to also know what patients are going through and what kind of benefit they can get with BESREMi. I've already felt as a hematologist that we've upgraded our therapy approach significantly in the past few years. That's a great thing for patients who have the condition now, that we can get them on a much better path long-term, where we can treat the underlying condition at its source, we can normalize blood counts, have symptoms largely stabilized, and then patients therefore can live their life and hopefully stay stable for the long term. And I think that's hopeful, it's exciting medically, there's a lot of great stuff in the research pipeline. We are on an upgraded path in terms of how successfully we can manage this condition, prevent complications of the condition. And that is a big deal because this is a cancerous condition. It is a big deal that we can do this now that wasn't possible just a few years ago.
You have to be patient, and I may not be able to hike that mountain as fast as I used to be able to do it, but I'm able to do it, so it'll just take a little time.
I think something both physicians have mentioned, that's something I've shared with advocacy groups too. We say we've come so far in 10 years. When you look forward and you're given the normal life expectancy right now is 20 years, how great is that? But if we've already come so far in 10 years, the next 10 years, that life expectancy and that normalcy might actually increase even more. So that kind of gives me hope for, as a younger patient, being diagnosed and wanting to live a full normal life.
Mental health problems, including suicide. BESREMi may cause mood or behavior problems that can get worse during treatment or after your last dose, including irritability, getting upset easily, restlessness and agitation, confusion, depression, feeling low, hopeless, or bad about yourself, unusually grand ideas, acting aggressive or impulsively, thoughts of hurting yourself or others, or thoughts of suicide. If you develop any of these symptoms, call your healthcare provider immediately. New or worsening autoimmune problems. BESREMi may cause your immune system to attack healthy cells, leading to conditions such as thyroid disease, increased blood sugar, hyperglycemia, or type 1 diabetes. Call your healthcare provider if you experience extreme tiredness, frequent urination, excessive thirst. Heart problems. BESREMi may cause heart problems, including cardiomyopathy, heart muscle disease, heart attack, irregular heartbeat, atrial fibrillation, decreased blood flow to the heart. You should not take BESREMi if you have uncontrolled high blood pressure, congestive heart failure, a serious abnormal heart rhythm, narrowing of the arteries to your heart, certain types of chest pain, angina, a recent stroke or heart attack. Who should not take BESREMi? Do not take BESREMi if you have or had severe mental health problems, especially depression, suicidal thoughts, or attempted suicide. Have or had a serious or untreated autoimmune disease. Are allergic to interferon or any ingredient in BESREMi. Symptoms may include itching, swelling, trouble breathing, dizziness, or chest pain. Have certain types of liver disease. Have had a transplant and take immune-suppressing medication. Before using BESREMi, tell your healthcare provider about all of your medical conditions, including if you have any of the following: a mental illness, type 1 diabetes, heart or bleeding problems, problems with your immune system, hepatitis B or HIV infection, kidney or liver problems, are pregnant or planning to become pregnant. BESREMi may harm your unborn baby. Use effective birth control during treatment and for at least 8 weeks after your last dose. BESREMi may affect your menstrual cycle and could stop your periods. Do not breastfeed while taking BESREMi. What are the possible side effects of BESREMi? Serious side effects include low blood cell counts, Taking BESREMi can lead to infections, anemia, or bleeding problems. Call your healthcare provider right away if you develop weakness and tiredness, bruising easily, nosebleeds often, fever, chills, burning and painful urination, urinating often, or coughing up yellow or pink mucus, phlegm. Serious allergic reactions. Get medical help right away if you get any of the following symptoms: skin rash or hives, itching, swelling of the face, eyes, lips, tongue or throat, trouble breathing, chest pain, or feeling faint. Eye problems. BESREMi can cause severe eye problems with your retinas that can lead to vision loss or blindness. You should have an eye exam before and during treatment with BESREMi if you have diabetes or high blood pressure and also have retinal problems. Liver problems. BESREMi can cause increases in liver enzymes and liver damage. Your healthcare provider should do blood tests to monitor your liver enzymes and liver function before you start and during treatment with BESREMi. Kidney problems. Your healthcare provider will do blood tests to check your kidney function before starting and during treatment with BESREMi. Tell your healthcare provider right away if you develop any symptoms of a kidney problem, including changes in the amount or color of your urine, swelling in your ankles, blood in your urine, or loss of appetite. Tooth and gum problems. BESREMi can cause tooth loss and/or dry mouth. It is important for you to brush your teeth well, 2 times each day, and have regular dental examinations during treatment with BESREMi. Skin reactions. BESREMi may cause reactions such as rash, itching, and hair loss. Increased triglycerides. You may require blood tests to monitor levels. The most common side effects of BESREMi include flu-like symptoms, including tiredness, weakness, fever, chills, muscle aches and joint pain, itching, sore throat. These are not all of the possible side effects of BESREMi. Call your doctor for medical advice about side effects. You may report side effects to Pharma Essentia at 1-800-999-2449 or FDA at 1-800-FDA-1088.